right, so let's get started. What risk adjustment looks like today. And today we have CMS-HCCs that we've had for some time, but we also have HHS-HCCs now. So we're going to talk about that as well as the CMS-HCCs tonight. A lot of great stuff to talk about. The first thing you need to know is that way back in 1997, the BBA, or the Balanced Budget Act, that's where risk adjustment first kind of got its foothold. What they did was they took MA plans, or way back then they were probably Medicare plus choice, where they took those plans and they wanted to project what the cost was for the care of these individual patients. So they would take a year's worth of documentation and they would project with the chronic conditions what it was going to cost next year to take care of them. But this again started way back in 97, and a lot of people don't realize that risk adjustment's been around that long. Now, if you really want to know what they call risk adjustment HCC is, it's actually an acronym for hierarchical condition category coding. And so we kind of shorten it down to call it HCC. But really, you don't call it HCC. That's like saying I would like to have a glass of milk, but saying that I'll just have liquid. It's just one part of what risk adjustment does, but since it's kind of fun to say HCC, it kind of got known as HCC work, but in actuality, it's risk adjustment. So when we get to the nuts and bolts of what risk adjustment is, we need to know that it is actually a hybrid of traditional capitation. So if you're familiar with traditional capitation, then you'll be able to see the similarities in risk adjustment. If you're not familiar with what traditional capitation is, well, what that does is it takes managed care organizations, they pay a provider or a group a fixed dollar amount per month. So when people abbreviate that, and we abbreviate everything in the medical field, right? They call that the PMPM. So that's actually per member per month, how much we're giving out per member per month, and it includes all the services that that particular member is going to need for that calendar year. All right, that's how they kind of do traditional capitation. So what does risk adjustment do? Well, CMS was the first one to really gravitate towards risk adjustment and use this model. And when they started it, they were only they were funneling down to just inpatient people. So as we know, inpatient work deals with diagnosis coding, not necessarily what you're doing to the patient. And risk adjustment is all about the patient's chronic diagnoses. So therefore it was easy to pull inpatient diagnoses to come up with payments for these MA plans. Okay? But something changed in 2000. We had the Benefits Improvement and Protection Act, which we call BIPA, and Congress said that we're going to take all this data that we've been collecting and with the inpatient diagnosis codes, and we're going to a little bit more with it. We need more information. So they made another change, and they started with MA plans having star rating programs, okay? And the STAR, which it looks like it would be an acronym for something, isn't actually an acronym. It is just for STAR. And so what they did with this STAR program with the MA plans is they said, we're going to give you bonuses. And then during this time, we're going to give you bonuses if you have a 4 or 5 star rating, okay? And then you would get these in 2014. up to 2014. Okay, and so that changed how the providers were looking at MA plans, because it behooved them, I guess you could say, to actually do the list or work with the list of what the MA plans were wanting and Medicare was wanting to have for the patients. And this actually broke down to things like having your female patients get their mammograms, having your male patients get their prostates checked, having everybody get colonoscopies. And so you kind of saw a change in the EMRs as well during this time, where they were putting in the EMR, counseled, Miss Smith to have her colonoscopy and scheduled it for X date. And then when they came back, it would say, if she came in for another visit for whatever, Miss, Smith, had her colonoscopy on XYZ date, and then they would get a bonus for having these preventative services done. This was one aspect of the STAR rating. And the idea was to get the providers to more or less convince the patients to have these preventative medicine steps done so that the patient would be healthier and they could nip or catch, how you say, nip in the bud, or catch these chronic conditions ahead of time. Okay, and that was supposed to make society healthier and make our payments for healthcare lower. Now that's one aspect of the STAR rating. It kind of changes, but so they were giving these big bonuses, and these doctors were getting bonuses in the fact, like, if I were to pull a number out of my head and I would say every time one of Dr. Jones's patients got a colonoscopy, he would get a $50 bonus. So, that didn't seem like a lot, but when you see, 20 patients a day times 5 days a week, and, even if you get 1 or 2 patients a week to have a colonoscopy, over a month and a year, that could really add up. And so these providers, if they were on top of it, they started doing this. Okay, it worked really well. Then what they did is they had this gradual integration of risk adjustment going into effect. Now, mind you, everything that I just talked about kind of changed in 2014, but way back in 2007, they had things that actually risk adjust at 100%. And so if you say 100% risk adjustment payments for the majority of the MA organizations were happening in 2007. Okay, and then there was a few plans that weren't actually integrated until 2008, but they were really dealing with risk adjustment at 100% way back then. Okay. But not everybody knew what it was. Well, then what happens? The Affordable Care Act happens. And so then CMS comes in and they said, now the MA plans want to reduce the federal payments that are the MA plans are wanting to work with the government, and the government, of course, wants to reduce the amount of money that they're paying out. So they kind of close the gap of what these costs were happening around traditional Medicare. That was the idea. But ultimately it was that we're going to tighten the noose on risk adjustment, and bonuses aren't going to happen anymore. We're going to start penalizing you if you don't do these certain steps. Okay, but we'll get more into the steps later. So again, the Affordable Care Act changed everything, and it was fully implemented in 2014, and so that's now when risk adjustment was turned on its head. Okay, again, so there's some milestones there for you, mostly just to know that risk adjustment's been around for a long time. So what do you have? You have Medicare Advantage starts from current enrollment numbers. So in 2014, they had about 54 million people on Medicare in the U.S., but of those 54 million, about 70% are enrolled in traditional Medicare, and then 30% are in Medicare Advantage plans, or MA plans. Okay, so that gives you an idea. You've got traditional Medicare, and then you have these MA plans that came in and work a little bit different. I like to kind of think of them as the HMOs of Medicare. Now, let's backtrack one more time. Let's look at the comparison. In 2004, the number of people that were enrolled in private plans tripled from 5.3 to 15.7 million in 2014. Okay, so that kind of gives you an idea of the growth that's going on here with these plans. All right, so let me get a drink real quick. Excuse me. I get all excited and I start wanting to give you all this information, and it bubbles around in my head, and then it must draw on my throat. Makes me thirsty. So when you're looking at CMS risk adjustment programs, you have to know that the ACA, or the Affordable Care Act, or Obamacare, however you think of it, is going to make things change. It's evolving. It's a financial infrastructure that is actually supposed to preserve the private insurance market. So when I say that, the private insurance market isn't so private anymore, right? Because it's all federally funded. But that's the idea, that with risk adjustments, then they're able to have the money set aside to pay for the federal funding that's going into all these plans, the gold plan, the bronze plans, the silver plan, because everybody says, you know how they used to say, how are we going to pay for the ACA? Well, this is kind of how they're doing it, right? That's the idea. So risk adjustment is actually the anchor for the ACA. And if you have been around in the financial aspect of medical coding and things, you see this pendulum swaying from everything was all about CPT codes, right? That's how you got reimbursement. And now it's moving over to diagnoses, right? And you see that pendulum going over there, because that's what the ACA has done. And so for us people that are diagnosis coders by trade, we're all, yay, and for people that have always dealt with CPT codes, outpatient coders and stuff like that as being, how you're reimbursed, then they're scrambling to pick up on these diagnoses and get real savvy with them. But again, we have to remember, coding was originally done so that we could collect statistical data, right? That's how we knew how many people had breast cancer in Texas in the 1995. We could tell people that, and then we could tell you how many people that died with breast cancer in 1996. Because of what we coded. And then as well as what treatments helped the patients with breast cancer to survive longer. That's how we know that as if a person has breast cancer and they take a particular medication for 5 years afterwards, that they have less reoccurrence and all that other stuff, which I know you probably realize that. So that's really why we code. However, it just happens to be a convenient way to get paid, right? And so that's where the CPT codes play such a heavy role. And now that role with the ACA is kind of tilted, and I said that pendulum is swaying because risk adjustment is set up to look at the previous year of a patient's care, a full year of documentation, and project the risk or the dollar amount that needs to be paid out for the future year based on chronic conditions. So if you have a patient that has diabetes and asthma, then and they're a certain age and a certain demographic, then we know we need, let's just say $10,000 next year in the coffer to pay for this patient A. But if we have a patient B who has diabetes, COPD, and also has a diabetic manifestation where they're already getting ulcers plus obesity, well, then we know we need $30,000 to take care of that patient for that year, next year. And that's really how risk adjustment works. They're taking the data from one previous year to project the risk or the financial cost for a given group for the next year. And that stabilizes the financial aspect of insurance or Medicare, and the Affordable Care Act has thrown that into full drive. Now, just backing up a little bit, you can see why risk adjustment coders are in such demand now. And as I'm going to show you here in just a little bit, that we've always had for a long time now. I showed you that CMS has had HCC work or risk adjustment work for a long time, but because of the Affordable Care Act as of 2014, we now have HHA, Health and Human Services, now risk adjust. So it's not just people who are 65 and older or have end-stage renal disease on Medicare, it's everybody that gets one of those federally funded plans, the platinum, the gold, the bronze, so we can have babies, neonates now, right? We can have your average person, the age changes. So we're going to talk about how that puts a kink in some of the things that we talk about with risk adjustment. In 2014, again, this really says that we got rid of pre-existing conditions, which was great. Everybody loves that, and everything. But the ACA also put this in full. The plan went into full effect. The ACA went in step by step. If you remember, there was an first phase implementation, which was you can't deny somebody insurance because of a pre-existing condition, and then so then everybody said, how are we going to pay for that? Well, you're going to pay for that because of risk adjusting. We're going to be able to project. Not only are we going to project, but we're going to make sure that the providers are having the patients get preventative medicine done, like your colonoscopies and et cetera, because it'll make our people healthier. We'll be able to risk adjust at a lower rate because we know we'll catch we'll catch conditions earlier. That's the mindset. So when you have risk adjustment, you actually are going to have a higher mix of sick versus healthy individuals that are covered on the MA plan, because we don't have pre-existing conditions, and of course with the MA plan, Medicare, you really didn't have pre-existing conditions anyway. You just turn 65 and it all falls into place. But now, again, it's all about how sick the patient is with the chronic conditions versus if they're 65, et cetera. See how it changes everything? The focus is moved to chronic conditions. We've got to capture the chronic conditions so we can tell how much money we need to set aside for the care of each one of these individuals. And what does that mean about the MA plans? Well, they've got some major coordinating to do, right? The plan providers have to give really good documentation, and you have to have better MLR management, and member satisfaction also is very important. So when I talk about member satisfaction, I said that they were given bonuses for these tests like mammograms and stuff to be done, but with the star rating, member satisfaction takes on a new role as well. So the MA plans are held accountable to keep their members satisfied. How do they do that? Well, they make them take surveys. And what do they ask them? Well, you think, okay, well, they're going to ask them things like, that would make sense, were all of your questions answered? When you were diagnosed with diabetes for the first time, did you get diabetic education? Did you understand the nutritional plan that you were put on? Did the doctor make you feel comfortable, et cetera, et cetera? You would expect that, right? But that's not all. They also ask them things like, when you called your provider, how long did you have to wait on the phone before somebody answered? When you went to see your provider, did you have to wait in the waiting room for very long? How long did you have to wait? Was there a water fountain in the waiting room? Were you comfortable? Were they friends? Do they call you right back when you called and left a message? This is stuff that they've never done before. So if your provider is getting positive reviews, then they will in turn get more bonuses. If they don't, they will be penalized, okay? So this is all supposed to be coordinating the plan of care for the patient and keeping everybody on their toes and making sure that the patient is being taken care of. Ultimately is the goal. But when you think about it, it's whenever you have money involved and the money is tight, what are they going to do? The criteria, all these criteria go up, and the people that are doing great in the star ratings, whether it be collecting the chronic conditions, keeping satisfactory rates of your patients high and stuff, they're going to continue to get paid better than the people that don't have these things, and they'll be penalized. So you can imagine why there was a big uproar when they finally realized what was in the Affordable Care Act and everything. Some providers said, hey, this is great, and other providers said, oh no, this is going to be terrible. You're affecting you're getting in between me and caring for my patient. So, but that's all another story. Now, with CMS Risk Adjustment, and I told you there was CMS Risk Adjustment, and now there's HHA Risk Adjustment, or Health and Human Services Risk Adjustment. I keep saying HHA, and I mean to say HHS. I apologize for that. What is the difference? Well, with CMS, it's all perspective. So they take a whole year of documentation for a patient. So let's go back to Sally. Sally is 65, and they take a full year of documentation for whatever year. So let's just say that not this year that we're in right now, but the previous year, they collect all of that information, they send it to the MA plan, and the risk adjustment, or HCC coder, will look at every page of that documentation, which could be 30 pages to 1,000 pages, depending on how often that patient was seen face-to-face by approved CMS providers, which could be therapies, nurse practitioners, PAs, physicians, inpatient, outpatient, procedures, surgery centers. All of that information is collected. And so they look through and review the documentation, make sure it meets all the auditing standards required by CMS, like it's got to have the name of the patient, the date of service, the, blah, 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 stuff like that. And then they also collect all chronic conditions for that patient that risk adjust, and we'll talk about how many those are and stuff. So that's how they say, okay, this person has diabetes and this person, and COPD. They have 2 chronic conditions that risk adjust. It doesn't matter that they came in twice for a respiratory infection or that they stubbed their toe. That is in the documentation, but you don't collect data on that because it's not a chronic condition. And so those chronic conditions are converted into HCCs, like diabetes is a 19, and et cetera, and you don't have to have those memorized. But if you've been doing it for a while, you end up having them memorized. And then that 19 converts per the demographic and the information about the individual patient to a specific dollar amount. So let's say diabetes is a 19 and it pulls, and again, I'm just pulling numbers out of my head, $10,000. So that means $10,000 will be set aside for that patient, okay, for next year. Right, and then if they have a manifestation that would not be a 19 anymore, it would change numbers. Maybe it's an 18, and that sets aside $20,000. Kind of mentioned that before, right? Okay, so let's say you are a risk adjustment coder. You're looking at the documentation. You know that you have 30 pages of documentation, and you know your patient has diabetes that you're looking at because the doctor states the patient has diabetes. They're only seen maybe twice by the provider, but they're not seen for the diabetes. They're seen for an upper respiratory infection and the fact that they stubbed their toe. Okay, they're overall a pretty healthy person. They take no medication for their diabetes, but they control it with diet and exercise. But the patient is diabetic. So nowhere in the documentation does the provider treat or mention that the person is diabetic, except for one time it says, oh, by the way, the patient's diabetic. Now, you can't collect that as an HCC because you can't prove that they're actively being treated for diabetes. And that is a bummer. That is what risk adjustment coders get so frustrated about, and like, because you have to be able to show, not only did he say that the patient has diabetes in the diagnosis code, but we have to prove by the documentation this is actively being treated. Therefore, if the doctor states, Sally has diabetes, her diabetes is under good control, and she is, her insulin or her sugar levels, she checks every day, once a day, and that she is using diet and exercise to maintain her sugars. Okay, then you have a line. They have a diagnosis and they have a treatment showing that they've actively got it. You can't just give a diagnosis. You have to be able to draw a line. You might say, Sally is diabetic and she takes glucotrol. There's your line. Sally's diabetic and she's on insulin. Sally's diabetic, she checks her sugar levels twice a day. There's a line. Actively being treated. If that's not captured, diabetes, then that money that I mentioned before isn't set aside for the next year. So next year, let's say our patient who is diabetic, has no complications, does only diet and exercise. Next year, she starts having problems with her diabetes. She sprained her ankle. She put on 30 pounds. She was less active. She had several respiratory infections that year, and so with her weight gain, her sugars aren't working aren't very good, and this time she stubs her toe and it results in an ulcer on her foot. Now she has a manifestation. The ulcer is not healing properly because she has diabetes, and the doctor decides to put her on glucotrol. Well, guess what? There's no money set aside for her for that care because it wasn't captured the previous year. Okay, so what this does, it says that it predicts the future cost of the to the plan, the MA plan, by sick members and adjusts the payment accordingly. So that's why risk adjustment coders are also kind of like auditors, where they delve in and they find all of these chronic conditions and they draw these lines, but they're also educators to the provider. If you go and you get your CRC certification, you are kind of like a subject matter expert to help educate the provider that, hey, I know that our patient has hypertension and it's not really a problem per se. It doesn't do a standard risk adjustment, but it does have an RX risk adjustment, and so therefore we need to make sure that's documented every single time they come in, regardless of why they came in. We're not doing the same type of coding that the outpatient is doing. They're collecting the coding to get reimbursement for what the provider did for the patient that day. Risk adjustment is all about what's the chronic condition documented every single chance you get so that we can capture it and So it's separate. So you want to encourage the provider to do that, and you help educate them in ways to do that, and ask them, how can I, educate me as well on what type of documentation you're going to do so that I know how to, for you to capture these chronic conditions. Okay. So we also, and sorry, I keep saying so, I get so excited about all this. So the RA methodology uses CMS to adjust the payments for the MA plans. And then the plan is based on, this information is based on demographics, because we know it costs a whole lot more money to take care of a diabetic in Boston than it takes to take care of a diabetic in, the Ozarks of Missouri, where I was raised. The cost of living is higher, right? But it also includes age, sex, and health status of the members. Okay? It's a prospective model. We're looking at the previous year to project the future year for CMS risk adjustment. And it takes into consideration these HCCs, which I told you were hierarchical condition categories, and you'll never be able to spell hierarchical. That's a word I can't spell, so it's very easy to say HCC. And they have a relatively value. There's over 3,000 ICD-9 codes that risk adjust, but now that we're in 10, there's more. There's over, almost 3,200, and it'll just keep growing as the years go by, and diagnosis codes are spread out, because now we got laterality and all that other stuff, right? Okay. And we also need to be familiar that it's similar to how DRGs are done. If you know how that's done in hospital reimbursement, then if you're trying to say, well, exactly, what can I say this is like? It would be like the DRGs for inpatients. It's not exactly the same, but that's kind of the concept. And this methodology is based on diagnosis codes, or on procedural codes, CPT-4 codes and stuff like that for DRGs. But the HCC payment methodology is diagnosis codes, and the DRGs are CPT codes. What about Part C of the MA plans? It's different from traditional managed care, because the plans are actually going to get reimbursed higher for sicker patients versus reimbursed higher for healthy members. That's a huge difference. And the provider can treat a member whose chronic illnesses fall under these HCC categories, and there's like 79 HCC currently. And here's an example of what they look like. This is actually from FinaCode. They're the only encoder I know of that actually lists the HCCs with them. So if you take diabetes, E11.9, and this is all, they actually list all the versions. So we used to, way back when we were in version 12, then we went into 21, then we were in 21, 22 together, meaning that the HCC could change, but diabetes is pretty standard, it stays in 19, but we're now into 22, but we also have ESRD, end-stage renal disease, would be a 19 also. There's a whole group of MA categories that just take care of end-stage renal disease patients. And then I mentioned the RX-HCC, it pulls a 15 for diabetes, but things that you think are chronic conditions like hypertension, it actually doesn't carry the standard CMS-HCC, even though it's a chronic condition, but it costs them to provide medication for the patient with diabetes, hypertension. If you have a patient that has hypertension and it's not treated or taken care of, or they don't take their medication, then you could eventually end up with a patient with hypertension and CKD, right? Because we know those two diagnosis chronic conditions are more than cousins. They're more like sisters, or if you say they're cousins, they're like kissing cousins. If a person has chronic hypertension, they have kidney problems. If they have kidney problems, that causes them to have hypertension. And so we want them to take the medication, and so therefore they're going to project the cost for that. Now, I mentioned HHS. Diabetes also carries a 21 for HHS-HCCs, and that would be people who are not on Medicare. So that would be the 20-year-old that has diabetes, because of obesity, type 2 diabetes, because of obesity or whatever reason. And so that for HHS, and then let's say they're on the silver plan, it pulls a 21. Another example is COPD. Which is J44.9, and this is what it looks like when it risk adjusts. Again, you have the numbers actually changed. So it was a 108, then it became a 111, and all these numbers mean they constitute a dollar amount for an equation or formula. They have the RX, and then is 104, and it's a 160 for HHS. So this is what it looks like in your. So you would be calling risk adjustment every time you had a patient with J44.9, you'd log them down as an HCC of 111. One of the ones that did change, though, and this is really interesting because an old MI, which is I25.2, used to risk adjust, but that changed. It no longer risk adjusts. So when we were in version 12, it was an 83. But I think it was kind of used and abused. I think that's why they pulled it. There could be several reasons why they pulled that, but it no longer risk adjusts. So you can't collect any money for a person that has an old MI. However, you can pull an RX HCC. So if you're pulling those as well as a standard CMS HCC, then you can at least get an 89 out of an old MI. But it did risk adjust previously, but it doesn't now. Some of the plans are slow to pick up on that, but technically it doesn't risk adjust anymore. So they can drop diagnoses. They can add them back. And this is another point to tell you that it's really important to know the disease process when you're a risk adjustment coder and doing risk adjustment work, because you need to know about old MIs. Now it's 4 weeks instead of 8 weeks, right, that you classify something an old MI. So a disease process, medical terminology, the anatomy, all of that's involved with risk adjustment. Fun stuff. Here's another one that is for amputation, a status code that is often overlooked, and it shows you that it carries a 189. Because the cost of the care for a patient who has an amputation is different than a person who doesn't, right? So these are some that are overlooked that actually carry money that you do want to collect that. So every time the patient comes in, even if it's for a head cold and they have an amputation, you want it documented that they have an amputation. You're not coding that when you're coding the respiratory infection. You're doing that for the risk adjustment aspect of it for the future. There's no reason not to make this documentation. In fact, there's every reason to make the documentation and have your provider do that. And it's really funny when you're looking at the documentation and you see that the person has a below-the-knee amputation. There is Z89 519, and they go down and do the exam and have bilateral pedal pulses. I was get a kick out of that. Copy and paste and stuff. And here's an example of some other things that risk adjust. So hyperlipidemia and hypertension, I told you, don't risk adjust for a standard CMS, but they do risk adjust for the medication, and we want to collect that data. So then we get into what's the difference between the CMS risk adjustment and HHS. Well, HHS is a little different. It went into effect in 2014 with the Affordable Care Act, and it's a model for individual and small markets. It's all based, it's driven by the ACA, but it covers young to adult, right? And they are still doing the same thing with the CMS. They've got their data. They have a method to how they collect it, and the equations. They're trying to get results to project the evaluation of. They use kind of the RA model, but it's a concurrent model. Unlike CMS that takes a previous year and projects the future year, it takes the year that you're in. All right, so a diagnosis from the time period to predict the cost for that same time period is what HHS does. It's very different in that. It also uses demographics and it collects the diagnoses, but it does it differently in that its measures is cost on an individual, what it's anticipated to be for that year. So if you have a child that has, you have a 2-year-old that keeps getting ear infections, right? Then they're projecting, okay, how many ear infections did that child have, and do we need to put tubes in that child's ears? Then for that year, they need to set aside enough money to put tubes in that child's ear, or we're going to have even more buildup of cost. And so when you compare them again, CMS, previous year, they take in the demographics and they predict the next year, which is HHS does everything in the current year. It's the same in that it's risk adjustment. It's different in the way that they do it. Their model's a little bit different. And so depending whether you're a CMS, as we've always had in the past, or an HHS risk adjustment quoter, then it does make a difference in how you do the data. Oops, I went too fast. Okay, so again, it's all like comparing apples. We're all apples, but we're not all green apples. There's like a red apple. With CMS, you have 65 or older disabled, right? End-stage renal disease. You have unique conditions with low sample sizes because they're 65 and over. You don't have things like pregnancy and neonatal complications. So when they were coming up with the model for HHS and they were trying to use CMS as a to base that model on, it isn't easy to do that because of things like pregnancy and neonatal complications. How many people that are 65 and over get ear infections and need tubes in their ears, right? So, but they did base one on the other. And your RX spending is both are something that has to be captured, but CMS predicts non-drug medical spending and HHS predicts the drug and medical spending. Again, you can see why that would be different from, if you say geriatric age to neonates. Well, how many HHSs do we have? We have 264 full diagnostic classifications. Then they break them down into 127 subsets and then 100 of the grouping clusters. And that's where you get like the things that we had, like the 19 and stuff. You keep narrowing it down. So what is the actual intent? It's to offset the cost. It's all about money. But you have to remember that it's also based on location. So the HHS is going to use the formula the CMS uses, but really HHS, their purpose is to offset the cost for the state. They're saying they're doing an RA on behalf of the state itself is what they're doing. And for the HHS, you have individual risk scores. They make adjustments, and then they calculate the funds, and they transfer it in between the plans that way. Kind of fascinating. My background is all in CMS. HHS has only been around, again, risk adjusting since 2014, so it's relatively new, and it does all age groups, so it's got a learning curve to it. But as you know, the HHS models, they do adult, child, and infant, so it's based on age. They have 15 different models, and they have cost-sharing metal models is what they call, and that's where you get the platinum, gold, silver, bronze, or catastrophic plans. So whichever one you pick, so if you're a silver, then they take the model from silvers, and they base it on your age. And then you have a whole area of costs and expenses for your age, for silvers, for your age, for gold, and etc. How much they pay out. So really, risk adjustment, I feel, is the future of reimbursement. This is how our providers are eventually going to get paid. Now, we can't ever forget that we code for statistical purposes. However, it will always be easy because we're translating, and that translation, that language we use in codes, is a data collection friendly language, and so we will always be based on reimbursement in some way. But when you really boil it down to the end, we have to know the bottom line is the care for the patient. That's what everybody cares about, whether it be the federal level, the state level, the providers. We all care about what's best for the patient. And that's that. Bye, guys.